Hello, welcome to Adapt NCLEX, a place of knowledge, pack, and highly tested content. And today, I want to do some few questions on prioritization. So I'll go over the strategy that I had on my previous video. Um, I just want to go over again so that I give you guys more idea how to use this. You can use this method to answer any prioritization question, almost 99%. An idea is to be sharp, not expected. And so we'll go over it again, more points, and do some questions and see how you can apply this strategy. The whole test is about strategy. So if you have a strategy that can help you answer more questions, then you got to stick with it. Um, the reason why I came up with this is I realized most of the prioritization questions, there's specific things they're looking for. And it's difficult to do that in your head. We do that in medicine. You got to have a focus so that you can pay attention to that and use that focus or some focal point to use it to analyze each patient. Remember, every patient is a priority. Okay, so for us, they come in, they have a problem that need to be fixed. But who do you see first? Somebody that you need to attend to. That if you don't do anything about it, then the patient will no more be a patient. It's dead, or you get complication from it that they become a morbidity for that patient. So that's the whole idea. And so it's very difficult looking at these patients without having a strategy, a target, what you're looking for. Once again, each patient, for patient that they're going to give you is a priority, but you have to make up in your mind that, look, I'm looking for these keywords. I'm looking for those symptoms. And so this method, being sharp, not expected, is just a focal point for you to look at and say, okay, this is in the that strategy. If it's not there, I shouldn't worry about it. It's expected. But if it's there, I should be looking at it very careful. Maybe that's the right answer. So we'll go over it and then I will show you guys how to apply it. The first one is B. So B is breathing. And people sometimes get confused about what is breathing. So this is, I'm drawing the lung to, this is your trachea and this is your bronchial. Okay, these are the air collecting tube that will bring, inspire air into the lung. Okay, and you have cages that surround the lung. They have muscles that allow the lung to expand. So like intercostal muscles. So these muscles here, your ribs, and then your diaphragm. These are all portion of your breathing system. Okay. And so anything that affects them is a breathing problem. The examiner is not going to tell you, but you have to look at the presentation. You said, oh, okay, it's a breathing problem. So anything that affects the lung, so the lung parenchyma, this is the lung, inside the lung itself, outside the lung, pushing on the muscles affecting the lung, the diaphragm, and the ribs, they have a breathing problem. And so you're looking for keywords. So a parenchyma disease, inside the lung itself. And the way they present is they will give you some words like retraction. Okay, what is that? They won't tell you it's a breathing problem, but that's retraction or use of accessory muscles, use of accessory muscles. That means they're moving air going in. So air is going into the tube. So when these are the tube, anything related to tube is airway. It's not the breathing. That means they can take air in, but they're struggling to bring air inside. So that's a use of accessory muscle or retraction. Those are breathing problems. The other thing that they like is this, and it's classic that they like to ask, but they don't tell you. Blood stained sputum. This is another word for pulmonary edema. That means you have too much fluid in the lung that and the blood vessel breaks, and then when you have a sputum, it look like there's blood in it. You are not having a lot of blood, but just a little bit. The sputum look red, so that's pulmonary edema. So blood, you see the word blood thin sputum. Those thing words, when you see them in any, who do you see? Say to yourself, this is a breathing problem. So I should be careful and be looking at it with another eye. Say this is one of the B sharp. So the B sharp, you're looking for words that are inside. Anything that is known in the B sharp is expected. So it's just giving you a focus. Okay, I don't have to worry about it. This is the B sharp. I need to look at it with two eyes again and be careful about it. So that's the breathing one. The the second one is E. So E is electrolyte. So there's a kind of electrolyte in your system that cause problem. The idea is to ensure hemostasis. So we have magnesium, we have potassium, we have calcium, and we have sodium. And they involve in hemostasis of your body. Any change in them causes problem, especially for sodium. Sodium, worry about low sodium, like 120, anything less than 135 or 120. The problem you worry about, they have seizure. Okay. So low sodium. So this electrolyte can be low or they can be high. So very high electrolyte. So hyponatremia or hypernatremia. Okay, hypernatremia, where you worry about neurological problem. Calcium too is the same thing. Low calcium is neurological in addition to cardiac and muscle function. High potassium is not good. You know about potassium. High potassium or low potassium has cardiotoxicity effect and muscular effect. The same thing as magnesium. So you're looking for this in the who do you see and looking for those numbers. I see low potassium, high, then I have to worry about it. I need to look at it with the second eye. So that's the B aspect of it. The The next one is S. So S is two types. There's sepsis and there's shock. So sepsis, like talking about peritonitis. So that means you have infection. So bad infection is affecting your body system. Once again, they're not going to tell you that, but you have evidence of that. Like patient temperature will be high or low. What I mean is hypothermia. People who have sepsis, the temperature goes up or low. Their heart rate goes up because of the infection, and then their blood pressure can go down, and their respiratory rate goes up. So these three are the signs of sepsis. Something is the systemic, your system is trying to compensate for the inflammation, and so this goes up. Sometimes they give you a physical finding. So they say somebody is has surgery and his heart rate is high, temperature and blood pressure. That is sepsis. Or they can give you if it's in the abdomen, like peritonitis. Somebody had infection in the abdomen. They can tell you how his abdomen look. Look for rigidity, abdominal rigidity, or guarding of the abdomen. Okay. See, those are signs of um, peritonitis. Those are sepsis in the abdomen. So rigidity and guarding of the abdomen. Remember, most of the time when they're going to give you sepsis, it's going to be related to your abdomen. So like appendicitis, diverticulitis, any infection in your abdomen that will give you sepsis. Sometimes it may be after surgery or sometimes it's on the skin. So that's what you're looking at. Infection on the skin that is causing hemodynamic change. So temperature is going up, heart rate is going up, blood pressure is going down. That is hemodynamics. So those are sepsis. Then shock is the same thing. When somebody is in shock, their heart rate and their blood pressure goes down, their heart rate go up. Okay, and they will have acute change in mental status. And so They can give you a dehydration patient, somebody with interception or no, pyloric stenosis, or somebody who is diabetic, DKA, with hypotension or hypovolemia. This is all related. The main problem is the hypovolemia is shock. So you're looking for those signs that lead to shock, and then you have to do something about it because you're being shocked. So low blood pressure, heart rate, change in mental status, that telling you somebody is in shock. And the age is two. We already described it. So hypothermia. So the temperature is low. I'm talking about something less than 96, or the temperature is high. This is something you got to pay attention. There's some diseases that will increase your temperature really high. So, you see, there's so many diagnoses. So you have to put it together. Like one of them is NMS, okay? Neuroleptic malignant syndrome. Somebody taking antipsychotic, and they will have these symptoms. I will do another video about these diseases. They look the same. We have malignant hyperthermia, and then you have serotonin syndrome. You see these diseases, it fall under age with temperature going up. Neuroleptic malignant syndrome, malignant hyperthermia, and serotonin syndrome. All this, everything is ramp up. So everything is up, and they have temperature is very high, like 104, 105, tachycardia, tachypnea, and their temperature is so high, and they will have muscle rigidity. All this thing is a sign. This is the muscle that is giving them high temperature. So you can start thinking about it and said, you see that word, muscle rigidity. That word is not good. It's badness. So that is why you're looking for be sharp. So temperature can go high with these diseases, and when they give you these diseases, you have to see them first: neuroleptic malignant syndrome, malignant hyperthermia, and serotonin syndrome. The A, which we already talked about it. We're talking about the tube. Okay, that will bring air molecule into the lung, and the tube go all the way into your mouth. So this is the upper respiratory area, and this is the trachea, and then this is the bronchial. So anything that will block any of this is a problem. How would the patient present? They won't tell you it's an airway. So they will tell you a patient is restless. That's your clue right there. In your exams, anybody who is restless is not good. It's not like they want to be restless. It's an airway problem. Okay. Somebody is anxious. All of a sudden is anxious. That's an airway problem. That's your clue right there. Or somebody who is striding. So strider. So those are the words you're looking for. Buzzwords. The B sharp is full of buzzwords. Okay. Strider. So that's the. Or the drooling. Okay. These four, as soon as you hear them, worry that that may be airway. That's airway. Look at that question, answer choice carefully. It's an airway problem, and that patient you need to see. And of course, on the B sharp, airway is number one. Okay, so that's you're looking for restlessness, anxiety, anxious, not just a psych patient, but is anxious. All of a sudden they're anxious about something, and then they sick about something, and then they're anxious. Strider or Drilon, those are your clue. You need to see these patients. It's an airway issue. Then the R, I usually describe it neurological. So anything neurological, but what is that? Acute change in mental status. So all of this is sudden, they confused. Okay. I'm not talking about somebody with dementia and is confused. That is expected. Okay. I'm talking about somebody in the hospital all of a sudden is confused. Well, you don't just get confused, something is wrong. So we got to figure out why all of a sudden you confused. You are a priority patient. We need to see you. Or somebody who just had a seizure. It's a neurological problem. Something happened that they go into seizure. You need to see them. They can have a airway issue. They can have neurological issue. They can have so many things. So you need to see them. Okay, and sometimes when you really in a state of neurological deficit in your brain basically shut down, so you become lethargic. That's why when you're hypotensive or dehydrated, your brain doesn't get enough fluid, and so you become lethargic. It doesn't get enough energy, so you become lethargic. So lethargy, acute change in mental status, and seizure. And sometimes when you can't, your brain is not functioning. This is what I would. It's almost neurological and then respiratory. The one we're going to talk about. When your brain is functioning, the brain control your airway, some of the breathing system of your body. So the brain stem. So if you neurologically you are not functioning well, you can send signal to your breathing system to do what it's supposed to do. So patient will be grunting. So grunting. So grunting. So when you see these words, you should be thinking like, this doesn't look fine. So these are all word game. So that is how you're being sharp. And finally, the P, okay, which is pain. There's only three you should worry about. Pain that is going to cause you to lose your limb, you lose your life, and your eyesight. That's all. If I have acute pain to my eyes, I'm going to lose my eye. That patient, I'm seeing them like glaucoma. So acute angle glaucoma. That patient, you need to see them. Retina detachment. You see, you got to see them. Anything that is no, I'm not talking about cataract or they have eye infection. This is like acute. If you don't do anything about it, the eye is being lost, and you don't want somebody not to be blind, so that patient can be seen. Limb, they're going to lose their limb. So this is the common one is compartment syndrome. The patient he has cast in place. You give them pain medication, they still complain of pain. Yeah, that's your sign. Pain that is not relieved with pain medication. Yes, I'm not talking about claudication. He's walking, he has pain, and he stops, and the pain goes away. When he stops, pain goes away, he's relieved. So it's not a problem. Okay. So those are the clue you should be looking for. And then another one is like the rhabdomyolysis. They have somebody taking statin, and then they start having calf pain or muscle pain. So you have rhabdomyolysis or myopathy. This is their pain is not just a pain. These are ischemic pain. So pain that will make you lose your limb is an ischemic. Something tissue is dying. So this pain is ischemia. So the pain they're having is ischemia. So if you don't do anything about it, it will die. So like compartment syndrome or rhabdomyolysis. Those keywords you start thinking about, these fancy words, you say, oh, rhabdomyolysis is a priority patient. I need to see them. Okay. But you have to know what exactly they're talking about. Then life. There is certain pain. If you don't do anything about it, the patient dies. And example is heart attack. The pain somebody is having heart attack, the pain that they're getting is an ischemic pain. And if you don't do anything about it, they will die. So heart attack is because the tissue is dying, that's why they're having pain. Okay. It's different from sickle cell patient that you expect that kind of pain. They have back pain, they have leg pain when they have sickle crisis. It's different. So you have to distinguish between your head. So I'm talking about pain that will lose your life, will lose your limb, and you lose your eyesight. Okay. And so, Another example is somebody with ectopic pregnancy. So if he coming with acute onset, the female who is in the first trimester, like 8 weeks pregnant with the right lower quadrant pain, I know that kind of pain is different from somebody who come in with appendicitis pain, right lower quadrant fever and nausea. um, that is the appendicitis pain is not ischemia. It's just because infection. It's an infectious kind of pain, which we have some time to take care of that patient, even though it's um, peritonitis. They can go into sepsis. We have time. Somebody with right lower quadrant pain because they missed their period is a ectopic pregnancy. It's an hemorrhage problem. And so if you don't do anything, they die. So life, limb, eyesight. And this is just a summary of the B sharp. It lets you stay focused and you being sharp when you take care of somebody who is in this group of disease process. So we will use example and then we'll do some questions about it. Um, so so we're going to use um, this strategy to answer a couple of questions. So the same thing, we're going to be sharp about it. So we have a couple of patients. So a client, this is a short questions. A client with asthma exacerbation with a heart rate of 110 after albuterol. Fine, I know it's an asthma patient. Okay, so the way we're going to do this prioritization, we read each and when we eliminate as we go. Okay, so asthma patient has exacerbation. Okay, his heart rate is 110 after what? Albuterol. So asthma patient is treated with albuterol. His heart rate is 110. They is not telling me that this patient is having any airway issue. It's not airway problem. So I'm not going to worry because it's an asthma patient. All they're asking you is it was treated with albuterol. His heart rate is 110. Well, what is the side effect of albuterol? It acts on beta and beta receptors. And so there's beta receptors on your heart. Okay. So it binds to those beta receptors on your heart, and your heart rate goes up. You have tachycardia, right? You have palpitation. You have insomnia because you're going to be ramp up. It's like epinephrine, a little bit of epinephrine is acting on epinephrine receptors. And so all this is normal for your heart rate, and you have palpitation. So the nurse know that if I give the patient albuterol, his heart rate goes up. So this is unexpected. It's gone. I'm not worried about him anymore. The client with cholecystitis with right upper quadrant pain, nausea, and fever. Well, cholecystitis, you just have to look at it and know what it is. This is gallbladder, infection of the gallbladder. Where is the gallbladder? It's on the right upper quadrant. So one, right upper quadrant, check. Pain, fine. He has nausea, fever. That is what is expected when you have infection, cholecystitis, infection, there's fever and nausea. They're not telling me that the patient is in shock, they have peritonitis or sepsis. That's all they're telling me. Nothing. So this is expected. It's also gone. So I don't have a priority. A client with abdominal bruit, report of back pain. So this you have to know. So your belly button here, if you examine any patient in the abdomen and you hear a bruit, think about triple A. So AAA. This is dangerous. That means they have abdominal aortic aneurysm, and this can rupture. That's the problem. Back pain in this patient means rupture. And if rupture is a vessel, big vessel, all blood is coming out. And that is the H on the um, um this thing, the B sharp or the S. So they will go into shock. So shock, shock. So this is my priority. So the S is the shock. A client with backing cough with no retraction. So backing cough is not good. Okay, it's an airway issue. But what is the problem? No retraction. So it's not having, sorry, backing cough is a breathing problem. But what is it? There's no retraction. So there's no evidence that they're struggling um, to to breathe. So even though this may be a B problem, there's no retraction. So it's not struggling. So I would take the airway, the breathing um, patient over this one. Even this is the airway issue, there is no evidence that it is struggling with that. So no breathing. So the answer should be B. No, three. The same thing, same strategy we're going to use. Who do you see first? A client with periumbilical ecchymosis after kidney transplant, kidney biopsy. Well, your kidney is at your back. Okay, you have two kidneys here, like that. And they like asking this question. Kidney is a vascular organ. Okay, it has a lot of blood going there. So whenever we do biopsy, the complication with kidney biopsy is hemorrhage. So when this patient, after anybody who have kidney biopsy, your assessment after that is you're looking for S, shock. Okay, shock presenting with what? Your blood pressure low, heart rate high, and change in mental status or decrease in urine output. But they won't tell you. You see how this is the tricky one, periumbilical ecchymosis. Well, now, what this sign means is they have bled to the point. The kidney is at the back. We call it retroperitoneum. It's at your back. So when they bleed into their back, and then it will make its way to the front. And so they bled retroperitoneally. And periumbilical ecchymosis, it has a name. It's called Cullen sign, Culln, Cullen sign. So when you see this, that is hemorrhage. Patient is hemorrhaging. So it's going to be in shock, okay? And therefore is a priority, but we got to keep it and look at the other ones. A client with sickle cell with a severe back pain. Well, sickle cell, it look like it's in crisis. When they're in crisis, they have pain everywhere. So this is unexpected. So I take him out. A client with esophageal varices, okay, being treated with SB tube. This is the balloon tube. Now with restless. So this is a tricky one, okay? When you have esophageal varices, they use the SB tube to tamponade the varices. So it's a tube, it's a balloon, it's like a Foley catheter with three-way catheter, and it come out from your mouth, and it has three-way, and they blow it up and they stop the varices from bleeding. One complication of this is sometimes the tube can migrate and it go into your upper airway and it causes respiratory distress and it become airway. Even though we're treating a breathing problem, it turn into airway. So any patient with the SB tube or balloon tamponade tube now with restless is having airway obstruction. So this now become our priority. I take A over the B who is bleeding. So this is our priority. A client with COPD and saturation of 92. Well, don't worry. You have to know COPD patient, if his SAT is 99, something is wrong. You never see a COPD patient with SAT of 99. They live in like 89 to 92. So these are enormous, these are clinical things you have to know. 89, 92. Their SATs are never normal. If it's 99, well, you got to figure out it shouldn't go that high. So 92 is normal for them. So this is fine. So the answer is A, 8. And the third one. So you see what we're doing. We're being sharp. We are not being expected. We're just being sharp about everything. The same strategy. We have four. Who do you see first? You read them and you eliminate as you go. A client with multiple sclerosis report of bowel incontinence and weakness. I know multiple sclerosis is a demyelination issue. Basically, the nerves losing myelin. Okay, so myelin are fat on top of the nerves, and it helps the nerve transmit information quickly. Multiple sclerosis people, they don't have myelin. Myelin is gone, so information take a long time. So they have neurological issue, mostly bowel, bladder, weakness, and the disease go on, relapsing and remission. So bowel problem is fine with me. Muscle weakness is fine with me. These are all expected. The only thing that is a priority for these patients, if they start having muscle weakness, problem swallowing of their muscle that controls swallowing. So if they have swallowing or speaking issue, yeah, that's when I worry about it. But that one is unexpected. So this is E. I want to be sharp, not expected. A client with ALS, okay, complaining of fatigue and weakness. The same thing. There is four classes of neurological problem that the symptoms look the same, and your SATA question look for airway. ALS, the same thing. They have progressive um, problem, weakness due to neurological neuron destruction of their nerves in specific area of their brain, the brainstem and the motor system, which is the spinal cord. So when they have spinal cord, the motor neurons in the spinal cord is not working, they already defected, they have weakness. If the brainstem is completely destroyed, the brainstem control breathing, so your respiration. So you're looking for airway issue in this patient. Having fatigue and weakness is due to the weakness of the spinal nerves in the spinal cord. So that is expected. You expect them to have bladder problem, bowel problem, muscle problem. But as soon as they affect their breathing, the muscles that control their breathing, they are swallowing, yeah. So this guy, fatigue and weakness is okay. It's expected. I'm looking for and swallowing and then problem speaking. Yeah, that's another sign. Okay. The same thing. Guillain-Barré syndrome is the same thing. They too, they have the same thing, but they are weakness start from their leg. It's because of the distribution which neurons are destroyed. You don't need to know too much detail, but they get weakness from their leg and it goes up. So ascending paralysis. So they start getting paralyzed from their legs all the way to their head, abdomen, before you get to their neck. And the neck muscles start having problem. And so that day too, they're looking for swallowing and breathing problem. And so because this patient has a swallowing problem, he's going to aspirate. I need to do something about. Most of them they get a like tracheostomy or uh, um, gastrostomy tubes to feed them because the muscles, muscles for swallowing doesn't work anymore. So this is um, your answer for now. So it's not expected because he has swallowing problem is a priority. The client with myasthenia gravis with weakness at the end of the day, you know myasthenia gravis. Its problem is the acetylcholine receptors. There's antibody destroying it, so it destroy the it bind to the acetylcholine receptors, and the normal acetylcholine doesn't bind. And so what happens is these people they usually stronger during the day. They're stronger during the day, when they wake up in the morning, they're stronger, but as soon as they start working, they get weaker, weaker throughout the day. The major problem is the swallowing. They too, they have swallowing problem during the getting to the end of the day. So in the question, they may ask you, how do you treat this patient? You let them take their medication during the morning. If they have to do activity, they do it in the morning. Um, because during at the end of the day, from the afternoon going to the evening, They get weaker and weaker and weaker. And so this is an expected finding. So A3 is our priority patient. So we have a client, for client, a client with right testicular pain, right testicle elevated compared to the left testicle. So if this is your scrotum and this is the right and this is the left, where the left is there, but the right testicle is up here and the patient has pain. When you see this testicle height has changed and there's pain on the one that is on the upper end, this is what we call torsion, testicular torsion. This pain is an ischemic pain, so pain that they will lose their life or limb or eyesight. Therefore, this is a priority patient. But I got to check if there's somebody there. So this is a priority. Okay, I have to be sharp about it. I don't want this dude to lose his testicle. It's a torsion, so it's a priority. It's an ischemic pain. It's this pain, you cannot ignore it. So we got to do something about it. A client with sickle cell with back pain, expected kind of pain. You expect them to have back pain, which is during exacerbation. So this is expected. A client with unilateral head pain and history of migraine. Well, if you have migraine, you can have exacerbation. So this is an expected pain too. A client with left lower quadrant pain and fever and a white count of 13. Okay, you say, fine, this guy is infectious. He may be having sepsis. Appendicitis is never, um, even though it fall under sepsis, you have time. We have time to do something about it. He's not going to lose his limb or life or eyesight. It may go into sepsis. We don't want him to go to sepsis. So this patient will probably is the second patient you see. You get the antibiotic and then you treat them. So he's a second patient. So this one is sepsis. Okay, you don't ignore it. It's sepsis, which is the S on the in the B sharp. But why do you have to pick the this one? It's because he's going to lose his testicles. You don't want that. Pain that will let you lose your limb or eyesight, where I'll choose this one first. Rather than be somebody I can give antibiotic, I have some time. You never develop sepsis right away. So this patient, he has time to take care of him. So the answer is A. So another fancy one. Who do you see first? A client with frank ecchymosis after liver biopsy. The same thing. So there's two ecchymosis after liver biopsy or kidney biopsy. So the same thing. The liver is on the right upper quadrant. Now they have ecchymosis on the frank. Okay. So this is where they have the ecchymosis. These two things you have to know. You can get ecchymosis here, which is periumbilical. This is the curling sign, and this is the gray tenor sign. You hear a gray tenor sign. This is not normal. This ecchymosis is not normal. That's bleeding, bleeding, bleeding. That's hemorrhage right there. They are hemorrhaging. So hemorrhaging, that go under shock. They will go into shock. So their heart rate will go up. So anybody who have liver biopsy, look for heart rate going up, blood pressure going down, and ecchymosis around the flank or periumbilical or urine output going down. So this one is shock. So we have to be sharp. So that's a priority. A client with back pain after cardiac catheterization. This is the same. When you do cardiac catheterization, they go into your groin. Okay, this is your groin, and they go into the femoral artery, and they go all the way into your heart. Okay, when they come out, you have to check their groin. You do neurovascular check, and then you check their groin for hemorrhage, and you look for them. Your assessment after cardiac cath is shock. So you're looking for increased heart rate, decreased blood pressure, and change in mental status. These are all really important topics you have to know. So I intentionally put them all together. And therefore, these patients need to be seen as soon as possible. But guess what? This is hemorrhage, which is shock. This is also shock. So we have two shock there. A client with periumbilical ecchymosis after pancreatitis, the same thing. Pancreatitis, when you have pancreatitis, you have inflammation around the pancreas, and there's vessels around the pancreas. The pancreas is retroperitoneum, and you can have bleeding. It look like the kidney where you bleed into your back and it go into the periumbilical area. So this is also shock, that's bleeding. So these three patients, watch these symptoms when they give you in your test. It's a form of shock. That's how they can present it. Somebody with a liver biopsies with ecchymosis around the flank, catheterization with the back pain, ecchymosis in the with pancreatitis at the periumbilical. These are all shocks. So we have three shocks. That means, who do we see? Well, a client with drooling and restless after sore throat. He has sore throat, and now he's doing what? He's drooling and he's restless. That's your airway. So I pick this. In your test, they're not going to do that. They're not going to give you three shock symptoms. I intentionally do that. I just want to emphasize these key diagnoses. So the answer is number 4. Maybe this may be the last one. I forget the questions. So who do you see first? The same thing. A client with Raynaud disease with blue fingers and cold after cold exposure. Yeah, these people, they are vessels, okay, that go to their hand and then go spasm with extreme temperature. So either you go up in temperature or you lower the temperature extreme. So hypothermia will make the vessels go into spasm. So, and it will cause ischemia. But then when you warm the hand, it goes away. So the other way you can think about it is claudication of their vessels into their fingers. That's the way you can put it in a simple way. And so when you warm it, as soon as you warm it, they get better. So this is not a problem. Just a knowledge check. You can treat this with calcium channel blocker. So calcium channel blocker, like the thiazide cream. You let them put the thiazide cream on your hand, and it relaxes the muscle, it dilate it and allow blood to flow. So that's in case you see a question like that. So this is expected. We have to be sharp. A client with calf pain when walking, which resolve with rest. So claudication, when he has a little bit of ischemia when he stop, but when he stop, the blood flow back and it get better. It's the same thing as Raynaud. So this is expected. A client with heart failure with a BNP of 500. Don't worry about the 500. Okay? When you have a heart failure, your heart stretches, and there is a hormone that is released, that is the BNP, and the level goes up. Normal is 100. So anything above 100 is the actual diagnosis of what? Heart failure. So this patient, they're not telling me he's in shortness of breath. They're not telling me he has pink, fruity sputum or blood thin sputum. Those are all pulmonary edema. So blood thin sputum or pink thin sputum or fruity pink sputum. All of them shows pulmonary edema. In heart failure, you worry about this. Pulmonary edema should be your number one, not BNP of 500. Pulmonary edema, breathing problem. So I'm not choosing him. It's expected. So we left with this. A client receiving blood transfusion with the back pain. this pain is going to lose a limb or eyesight. You shouldn't be getting pain when you're getting blood. This is what? Transfusion reaction. You need to stop the transfusion right away. And when you stop the transfusion, one thing you should do in your exams, if they give you a SATA question, leave the IV in place because you may need IV to transfuse, to give them blood or to give them fluid to help with that. So don't remove you just stop the tube. You remove the tubing that the blood is going through and you send it to the lab to be taken care of. But this patient need airway management and fluid resuscitation on the patient. Don't remove their IV because you will need it to give them fluid. And this is all. So as you can see, it's just application of um, the um, the prioritization. You just being sharp. It's just guiding you, not expected. And it has key buzzwords in it, and you just stay within it. Okay, you stay within it. I'm looking for things in this because these are dangerous stuff. If it's not there, then it's an expected finding. So take care of yourself and subscribe to my YouTube channel and Facebook, and so that I can grow my channel. And I'll expect more um, highly testable content. And then any comment is appreciated. Once again, keep charging and never stop charging. Good luck in your exams.